Hello and welcome. I'm Dr. John Kelly. Neither of us have any conflict of interest. The purpose of the course is to present the evidence that intensive therapeutic lifestyle change, known as ITLC, can reverse most insulin resistance and type 2 diabetes, to prepare and equip physicians and other clinicians to conduct evidence-based intensive lifestyle interventions capable of reversing insulin resistance and type 2 diabetes, and to describe key steps needed to establish reimbursable intensive lifestyle medicine type 2 diabetes reversal treatment programs. Why is this needed? What learning gaps does it fill? The goal of diabetes care has been management to slow the progression of complications, but new research shows that reversal of insulin resistance and remission of type 2 diabetes are more appropriate goals, such as a paper published by Kelly, Carlson, and Steinke, American Journal of Lifestyle Medicine in 2020. Also, mixed results from intensive lifestyle medicine treatment studies, including Gregg, Lim, Lean, confuse lifestyle medicine clinicians treating type 2 diabetes. Recent analyses, such as the one mentioned by Kelly, Carlson, and Steinke, reveal that lifestyle medicine dosing is critical. More intensive dosing is required for reversal and remission. Finally, the importance and mechanism of insulin resistance are poorly understood. Multiple ill effects occur before frank type 2 diabetes develops.
Physicians, nurses, and other allied health professionals will benefit from new information on the whys and hows of lifestyle medicine for diabetes remission and insulin resistance reversal. It's been estimated that it takes on average 17 years for new research to make it into practice. Those completing this course will be immediately prepared to address diabetes and insulin resistance in powerful new ways.
The course focuses on reversal and remission of type 2 diabetes using intensive lifestyle medicine treatment. Reversal and remission is becoming the accepted clinical goal. See Shabib et al. In Vascular Health and Risk Management 2022 for an excellent review of how to achieve remission using a full spectrum of treatment from pharmaceuticals to lifestyle medicine. The insulin resistance that occurs before type 2 diabetes develops with its many adverse effects also has a significant role in type 1 diabetes and LADA, latent autoimmune diabetes in adults. The course does not claim reversal of type 1 diabetes or LADA, but does show how reversing insulin resistance can improve these and other conditions. Our teaching faculty includes some of the most innovative physicians and other providers with proven success in reversing insulin resistance and producing type 2 diabetes remission. Many have published research and/or authored books about their topic areas. Lead faculty has conducted federally funded research on the use of lifestyle medicine to treat and reverse type 2 diabetes. After this first introductory module, the course covers the entire spectrum of science and practice related to type 2 diabetes and insulin resistance and their reversal and remission. Topics covered include key metabolic disturbances and pathophysiology of diabetes and insulin resistance, how disturbances are reversed, reversal and remission of type 2 diabetes and insulin resistance, what it is and how can it be identified, published evidence for reversal and remission, can lifestyle approaches to type 2 diabetes reversal and remission reverse established complications, for example, are additional modalities necessary? Type 1 diabetes, latent autoimmune diabetes in adults, and insulin resistance-related Alzheimer's, are any of these reversible? How does reversing insulin resistance affect type 1 diabetes, LADA, and insulin resistance-related Alzheimer's? Is lifestyle change part of optimal treatment? How and to what extent can metabolic syndrome be reversed by the same treatment as type 2 diabetes and insulin resistance? Effective modalities for type 2 diabetes remission and insulin resistance reversal is lifestyle medicine treatment versus other treatments, and reversal of diabetic neuropathy also non-pharmacologic modalities to reverse diabetic peripheral neuropathy. Essential characteristics of type 2 diabetes remission and insulin resistance reversal with lifestyle medicine, what physiologic changes are required, and what are the critical lifestyle changes necessary to accomplish that? How is it best accomplished? What setting, treatment intensity and duration? What team members and functions? What's the most effective outpatient and inpatient treatment components? Shared medical appointments, for example. Disease reversal and fasting. What is the nature of the required fast? How do fasting mimicking diet and time-restricted feeding affect type 2 diabetes remission and insulin resistance reversal? Essential aspects of diet to maintain type 2 diabetes remission and reversal of insulin resistance, an optimal dietary plan, and how it's best implemented and maintained. Is there a minimum physical activity required? What is optimal physical activity for reversal? How does sleep impact type 2 diabetes remission and insulin resistance reversal? Is there a minimum sleep pattern required or an optimal sleep pattern for reversal? What are the expected success rates for type 2 diabetes remission and insulin resistance reversal at 6, 12, and 24 months? Initiating and sustaining engagement in changes in lifestyle medicine, some useful knowledge and tools, and the key steps or processes for establishing a type 2 diabetes remission and insulin resistance reversal lifestyle medicine program. For example, evidence-based curriculum, certification, and reimbursement.
Now that you've heard what the full course will cover, let's dive into Module 1, Introduction to Diabetes Remission as the Goal of Type 2 Treatment. At the end of this program, participants will be able to discuss the historical perspective on the reversibility of type 2 diabetes. Define diabetes remission as described by consensus of the American Diabetes Association and the European Association for the Study of Diabetes. Interpret reports indicating very low type 2 diabetes remission rates in population-based studies. Describe how reversing insulin resistance promotes remission of type 2 diabetes, and describe the rights that people with diabetes are entitled to when they seek treatment. Objective 1. Discuss the historical perspective on the reversibility of type 1 diabetes. What would it mean if remission of type 2 diabetes was possible? Of course, it would have a tremendous impact. In 2016, the World Health Organization said that the number of people with diabetes worldwide has almost quadrupled in the last 40 years to 422 million people worldwide. In 2019, in the US, the CDC and the ADA found that 37.3 million Americans, or 11.3% of the total population, had diabetes. 15.9 million, or 29.2% of seniors 65 years and older had diabetes. In 2019, about 1.4 million new cases of diabetes were diagnosed. And for adults diagnosed with diabetes, 69% had high blood pressure and 44% had high cholesterol, 39% had chronic kidney disease, and 12% reported having vision impairment or blindness. Every medical specialty and practice setting encounters people with diabetes. Remission is possible, as we will discuss. However, according to a recently updated public-facing page of the ADA website, the downloadable booklet, Where Do I Begin?, still contains the line, "There is no cure." According to the National Institutes of Health National Library of Medicine website, diabetes is a lifelong disease. There is no cure. And a recent visit to the Mayo Clinic's website found there is no cure for type 2 diabetes. If these were your only sources of information, you would not have remission on your radar. The current disease management approach for people with type 2 diabetes is primarily aimed at regulating blood glucose and delaying progression of the disease. As a nurse practitioner in primary care, where I specialized in the care of people with diabetes, I was trained and exhorted to help my patients achieve tight control. I used a lot of medication to do so. Remember the expression, if all you have is a hammer, everything looks like a nail? These are photos of the practice's medication closet and fridge, well stocked with samples. I was very successful at helping people achieve diabetes control, at least in the short term. I had many patients who had A1Cs below 7%. Diabetes medications were used very aggressively. I was also quite good at providing instruction on carbohydrate counting and multiple daily injections. We were among the first primary care offices to put patients on insulin pumps and provide labor-intensive oversight. However, even with lots of medications and good numbers, I had patients develop kidney disease, vision loss, heart attacks, strokes, and more. It was devastating. I also had patients who complained about the high cost of medications and the frequent monitoring required to avoid hypoglycemia and medication side effects such as weight gain. It led me to wonder, is there a better way? I had been taught that diabetes is a progressive disease and that once on insulin, always on insulin, and most people with type 2 diabetes will eventually need insulin. Fortunately, for the past 16 years of practice, I've known these statements are not true and learned that there is a much better way to provide care. It has been a professional and personal joy to offer my patients with diabetes the option of tight control, normal A1Cs, and overall better health through highly effective, safe, and affordable lifestyle medicine interventions. Are you familiar with the oculoglycemic reflex? Probably not, because I made up the name to describe this phenomenon. A well-meaning clinician, like me in the past, sees an elevated hemoglobin A1C and reflexively prescribes medication. Medication, of course, is beneficial in some situations, but in type 2 diabetes, we often over-rely on it and do our patients a disservice. By participating in this course, you'll be equipped to halt this well-ingrained reflexive behavior. Historically, we've been taught that type 2 diabetes is a progressive disease, one that at best can only be managed and complications of the disease hopefully delayed. The primary focus of professional and continuing education has been on pharmaceutical interventions. For most of its history, there was no standard definition for remission of type 2 diabetes because remission was thought to be rare. Let's look next at how researchers and clinicians currently define remission. John?
Thank you, Carolyn. Now, learning objective number 2 is to define diabetes remission as described by consensus of the American Diabetes Association and the European Association for the Study of Diabetes. The advent of bariatric surgery, now called metabolic surgery, ushered in the need for a standardized definition of remission because many patients who underwent this procedure experienced reduction of hemoglobin A1C levels to the normal range. A systematic review and meta-analysis by Buchwald and colleagues, Journal of the American Medical Association, revealed some remarkable outcomes from bariatric surgery. Diabetes was completely resolved in 77% of patients, and hypertension was resolved in 62%, hyperlipidemia improved in 70%, and sleep apnea was resolved in 86%. This strongly suggested that type 2 diabetes was not a progressive, irreversible condition as it was commonly considered at the time. In 2009, a group of experts, led by Dr. John Booz, published a consensus statement entitled, "How Do We Define Cure of Diabetes?" in the journal Diabetes Care. They began by writing, "The mission of the American Diabetes Association is to prevent and cure diabetes and to improve the lives of all people affected by diabetes. Increasingly, scientific and medical articles and commentaries about diabetes interventions use the terms remission and cure as possible outcomes." In summary, their consensus definitions included three categories: partial remission, where hypoglycemia below diagnostic thresholds for diabetes for at least a year's duration with no active pharmacologic therapy or ongoing procedures. Also, complete remission, which was normal glycemic measure for at least 1 year's duration with no active pharmacologic therapy or ongoing procedures. And finally, the third type, prolonged remission, which was complete remission of at least 5 years duration. Previously, there was only a task force studying what constitutes reversal or remission of type 2 diabetes. There was no official mechanism for establishing that a patient once diagnosed with type 2 diabetes no longer had it. Logic, however, suggested that if a patient with diabetes no longer met the established criteria for the diagnosis, their diabetes had been reversed. Other diabetes researchers and organizations have proposed other criteria for remission. So in 2022, an updated consensus statement was published by the American Diabetes Association and the European Association for the Study of Diabetes in Diabetes Care and other journals, representing the major international diabetes organizations. They stated, significant behavior changes, mainly related to nutrition and weight management, can lead to a return from overt hyperglycemia to nearly normal glucose levels for extended periods of time. Of course, they were citing studies such as Lean's Direct in Lancet and Greg's Look Ahead in JAMA. Going on, more dramatically, surgical interventions can induce significant weight loss with prolonged improvement of 5 years or more in some cases. Their definition of remission was an hemoglobin A1C less than 6.5% for 3 months without diabetes medications, or a hemoglobin A1C less than 6.5% for 3 months after surgical intervention and 3 months after cessation of diabetes medications, or a hemoglobin A1C less than 6.5% for 6 months after beginning lifestyle intervention and 3 months after cessation of diabetes medications. Is there an alternative approach to achieve remission? Yes, and it's not new. Although the websites cited earlier do not reflect it, information on remission is not new. Let me introduce you to Dr. James Anderson, Chief of Endocrinology at the University of Kentucky in Lexington. His research on how type 2 diabetes could be reversed was published in 1979 in the American Journal of Clinical Nutrition. The effects of high carbohydrate, high plant fiber diets on glucose and lipid metabolism in 20 lean men receiving insulin therapy for diabetes mellitus was evaluated on a metabolic ward. All men received controlled diets for an average of 7 days, followed by high-carb, high-fiber diets for an average of 16 days. Diets were designed to be weight-maintaining, and there were no significant alterations in body weight. The daily dose of insulin was lower for each patient on the high-carb, high-fiber diet than on the control diet. The average insulin dose was reduced from 26 units per day on the control diets to 11 units per day on the high-carb, high-fiber diets with a p-value of less than 0.001. On the high-carb, high-fiber diets, insulin therapy could be discontinued in 9 patients receiving 15 to 20 units per day and in 2 patients receiving 32 units per day. Fasting and 3-hour postprandial plasma glucose values were lower in most patients on the high-carb, high-fiber diets than on the control diets, despite lower insulin dosing. Serum cholesterol values also dropped from 206 milligrams per deciliter on the control diets to 147 on the high-carb, high-fiber diets, again, p-value less than 0.001. The study concluded, quote, "These studies suggest that high-carb, high-fiber diets may be the dietary therapy of choice for certain patients with maturity onset type of diabetes." And Brenda Davis, the matriarch of nutritional treatment to reverse diabetes, says, In the scientific literature, it's been well established that diabetes is a reversible disease. And Dr. Joel Fuhrman agrees. We won't be controlling your type 2 diabetes, he says. We'll be having you become undiabetic. So Carolyn, tell us about a nurse who turned her diabetes around.
Let me introduce you to a person who was diagnosed with type 2 diabetes when she was 41 years old, after having gestational diabetes 11 years earlier. We'll call her Dee. She kindly gave permission to share her experience. At the time of diagnosis, she weighed 252 pounds. Her BMI was 40.6. Her hemoglobin A1C was 7.5%. She was started on metformin and Diabeta, an older sulfonylurea pill. In 2013, Dee had had type 2 diabetes for 16 years after her diagnosis. Here she is with a new grandbaby. Her A1C was 6.6%, which her physician, based on standards, told her was great diabetes control. Her BMI had come down from 40 to 34.8. She was on 4 medications for her diabetes: liraglutide, a GLP-1 agonist, which was expensive back in 2013. I don't know what it cost then, but in 2022, the average wholesale price is $1,022 for a 30-day supply. She was also on metformin, lisinopril, and simvastatin. Even though she had what was described as great diabetes control, she wasn't feeling great. She was nauseated all the time. She was frustrated with her weight, and she was worried about the risk of complications and worried that she wouldn't see her grandchildren grow up. In 2017, Dee made the change to a whole food, plant-based dietary pattern. Within 2 months, she was able to stop all of her medications. These photos on the right were taken a year after diet change, when her A1C was 5.5%, her blood pressure and cholesterol were within normal ranges off all medications. She is seen here holding her second grandchild. This case is remarkable for 3 reasons. First, Dee had type 2 diabetes for a long duration, almost 20 years, when she achieved full remission, which as of this date in 2022, she has now maintained for 5 years. Second, Dee would have been a candidate for metabolic or bariatric surgery, yet achieved her remission with lifestyle changes. A third reason that I love this case study is because as a nurse in practice, Dee has now gone on to influence many patients and colleagues who also now know that remission is possible, even for someone who has had diabetes for many years.
Great example of the power of lifestyle medicine to not only put type 2 diabetes into remission, but to return it to full normal glycemia. Let's now look at the reports of very low remission rates in large population studies. In Diabetes Cure 2014, Carter et al. Studied the incidence of remission in adults with type 2 diabetes in the Diabetes and Aging study. Their objective was to estimate the incidence of remission in adults with type 2 diabetes not treated with bariatric surgery and to identify variables associated with remission. They quantified the incidence of diabetes remission and examined its correlates among 122,781 adults with type 2 diabetes in an integrated healthcare delivery system. This study was done before the new 2022 consensus, so remission required the absence of ongoing drug therapy and was defined as follows. 1. Partial remission was at least 1 year of subdiabetic hyperglycemia with A1C levels between 5.7 and 6.4%. Or 2. Complete remission, at least 1 year of normal glycemia, hemoglobin A1C level less than 5.7%. And 3. Prolonged, which was complete remission for at least 5 years duration. The incidence density, which is remissions per 1,000 person years, of partial, complete, or prolonged remission was 2.8, 0.24, and 0.04 respectively. The 7-year cumulative incidence of partial, complete, or prolonged remission was 1.47%, 0.14%, and 0.007% respectively. The 7-year cumulative incidence of achieving any remission was 1.6% in the whole cohort and 4.6% in the subgroup with new onset diabetes less than 2 years since diagnosis. The correlates of remission after adjusting for demographic and clinical characteristics included age greater than 65 years, African American race, less than 2 years since diagnosis, baseline A1C level less than 5.7%, and no diabetes medication at baseline. The conclusions were, in community settings, remission of type 2 diabetes does occur without bariatric surgery, but it is very rare. I quote, "The chances of dying were higher than the chances of any remission." Actually, it's more appropriate to call this spontaneous remission of type 2 diabetes in this population receiving the standard care for diabetes. I say spontaneous remission because the standard of care provided no treatment for the underlying cause of type 2 diabetes, poor lifestyle choices. Without such treatment, it would be unreasonable to expect remission. Next, we want to examine how reversing insulin resistance promotes remission of type 2 diabetes. It is known that serum insulin levels rise well before serum glucose begins its climb into prediabetes and then frank diabetes. This is due to the development of the insulin resistance that precedes and largely contributes to the development of type 2 diabetes. In an analytic review in the American Journal of Lifestyle Medicine in 2020, the authors state, "The underlying causes of type 2 diabetes have long been identified as excess weight and insulin resistance. There's been a lack of consensus on whether insulin resistance may be caused by excess weight or whether the excess weight is caused by insulin resistance. It has been suggested that there is a bidirectional relationship. However, one thing that these two causes have in common is that they most often result from excessive caloric intake. This causes rapid insulin resistance due to increased oxidative stress in as little as 1 to 2 days. This occurs before weight has been gained. Ongoing intake of excess, poorly chosen calories maintains the insulin resistance." The present review represents the position of the American College of Lifestyle Medicine on type 2 diabetes and remission treatment. Research now reveals that sufficiently intensive lifestyle interventions can produce remission of type 2 diabetes with similar success to bariatric surgery, but with substantially fewer untoward side effects. A literature review was conducted to examine lifestyle modifications targeting type 2 diabetes remission, with most studies using a combination of blood glucose markers and treatment history. There were notable differences in the dosing intensity of lifestyle interventions between therapeutic interventions, found in 5 trials, and subtherapeutic interventions, found in 4 trials. Studies with therapeutic dosing typically used very low energy diets, 600 to 1100 kilocalories per day, with a weight loss of 19.5 pounds or approximately 9 kilograms, and a weighted mean remission rate of 49.4%. While studies with subtherapeutic dosing typically used more moderate caloric restrictions, for example, reducing energy intake by 500 to 600 calories per day, with a weight loss of 7.7 pounds, which is 3.5 kilograms, and a weighted mean remission rate of only 6.9%. That would be a relative risk of remission of 14% compared to the therapeutic dose. Their conclusions: remission should be the clinical goal in type 2 diabetes treatment, using properly dosed intensive lifestyle interventions as a primary component of medical care for type 2 diabetes patients. We propose that remission should always be held as the primary clinical goal, and that lifestyle medicine interventions that produce changes leading to remission should therefore become the standard of care. There are certain logical consequences that naturally follow from this position. 1. The option for such treatment should be presented to patients in an informed consent process before other treatment offering minimal possibility for remission is prescribed. And 2. Reimbursement supporting this approach should be provided for such lifestyle medicine treatments. Remission should be the clinical goal in type 2 diabetes treatment, using properly dosed intensive lifestyle interventions as a primary component of medical care for type 2 diabetes patients. Focusing on the importance of properly dosing therapeutic lifestyle changes, they explain, in prescribing medications, dosing is absolutely critical. For example, acetylsalicylic acid, also known as aspirin, has multiple applications and physiologic effects in the body. For common headache, 2 325 milligram tablets every 6 to 8 hours are often prescribed, but for anticoagulation in atrial fibrillation, a single 81 milligram tablet per day is prescribed. To prescribe 81 milligrams daily for headache would be totally ineffective, and prescribing 650 milligrams every 6 to 8 hours for AFib would be dangerous. Lifestyle medicine is no different. With lifestyle medicine, dosing is determined by the intensity of lifestyle change prescribed. Mild change is often sufficient for primary prevention to avoid new onset of lifestyle-caused disease, whereas intensive lifestyle change is required to reverse disease and induce remission. They go on to explain a number of factors affect remission success, including the duration of diabetes, the degree of insulin resistance, and capacity of the beta cells to produce insulin. Also self-efficacy, including motivation and confidence of success in making lifestyle change. There are individual characteristics such as family and social support.
Thank you, Jen. We have one more objective to cover. Let's discuss the rights that people with diabetes are entitled to when they seek treatment. We can't talk about remission of diabetes without considering patient empowerment, and we can't talk about empowerment without discussing the ACLM Type 2 Diabetes Bill of Rights. I wanted you to see this and be aware that this document is available for you to download and print for your clinical setting. The Type 2 Diabetes Bill of Rights was developed by an ACLM Diabetes Task Force, of which John and I are members, with the idea that informed consent should be a part of diabetes care, and that informed consent should include the evidence for lifestyle medicine interventions for prevention, treatment, and remission. For example, the bill states that you have the right to be fully informed about all treatment options for type 2 diabetes before consenting to treatment. You have the right to be given accurate, complete, and unbiased information about type 2 diabetes, prediabetes, and insulin resistance, including the benefits of treatment with a predominantly whole food, plant-based diet, or other lifestyle medicine interventions such as physical activity, sleep hygiene, and stress management. And you have the right to work with doctors and healthcare professionals who understand the links between lifestyle choices and type 2 diabetes, and who are equipped with the knowledge and strategies to treat and reverse disease through therapeutic lifestyle change. Other rights include a right to understanding the benefits and risks of medications, the right to stop medications when appropriate, and the right to access ongoing education on whole food, plant-based nutrition, meal planning, and culinary skills, along with other lifestyle changes that offer the best chance of overall good health. I invite you to download the full document at the link provided, which includes a proclamation with full citations supporting each of the provisions. Read it in full, share it with your patients, and frame it for your waiting room wall. With this course, you'll receive plenty of information about the evidence for a whole food, plant-based dietary pattern. If this dietary approach is new to you or your clinical practice, be aware that in May of 2022, ACLM released an expert consensus statement about this dietary approach for remission of type 2 diabetes. The press release stated that a panel of 15 experts with representatives from 7 medical professional societies reached consensus on 69 statements related to using diet as a primary intervention to achieve diabetes remission. The expert consensus statement on dietary interventions is endorsed by the American Association of Clinical Endocrinologists, supported by the Academy of Nutrition and Dietetics, and co-sponsored by the Endocrine Society. The Endocrine Society is a global community of 18,000 plus endocrine investigators and clinicians from more than 100 countries. It is clear that now, more than 100 years after the discovery of insulin, we can offer our patients with diabetes much more than medication or surgical procedures. We can prescribe powerful, proven lifestyle habits that address insulin resistance and may lead to remission. We can help our patients to become the chair of their own health. They can make executive-level decisions to improve their quality of life. In the words of Dr. Dean Ornish, we can say, got type 2 diabetes? Get rid of it. As Dr. John McDougall has been saying and demonstrating for many years, a simple cure is possible for essentially everyone with type 2 diabetes. In summary, remission is the appropriate clinical goal in type 2 diabetes. Diabetes remission has been described by consensus of the American Diabetes Association and European Association for the Study of Diabetes. Low rates of remission in the past are due to the wrong or underdosed intervention. Interventions that address insulin resistance promote remission, and a Bill of Rights for type 2 diabetes supports access to accurate information and knowledgeable clinicians for people with diabetes.
Thank you for participating in this module. We wish you success in applying the principles and information you will learn throughout this course.